So let's talk and shift gears a little bit. Once you get the diagnosis of prostate cancer, once you get your Gleason grade, you know your PSA, you know your digital rectal exam, now what? What do we do, or how, as a urologist, determine how to treat your disease? It's not really a new concept, it's one of the concepts that's been around forever, but what we're doing more of is something called active surveillance. And what active surveillance is determining whether you need to be treated or not treated. It sounds crazy, but there's a lot of prostate cancer out there that's not going to kill you, that's not going to spread, so why do we have to treat it? Okay, and we're seeing more and more data about this where we can monitor your disease to make sure it never spreads or never be cause of your death. And that's the majority of the prostate cancer we see today is this low risk, low grade prostate cancer. And that's when your urologist will talk to you about active surveillance. It makes sense. We basically only do active surveillance on Gleason 6, low grade, low volume disease, or grade 1 disease. Sometimes, depending on the clinical situation, we may consider active surveillance for a Gleason 7 or a grade 2 disease. But that's a discussion you have with the urologist, knowing the good and bad of each of these to determine whether you want to do surveillance. The thing about surveillance is it's not you have it, see you later, call me in 5 years. It's we will monitor your disease. Typically, we repeat a PSA every 6 to 12 months at least. I do about every 4 to 6 months. And then you require repeated biopsies every 1 to 2 years to monitor it. The challenge that we have with active surveillance is, as a urologist and as the patient, do you have a tiger type prostate cancer or do you have a little kitten type prostate cancer? Is it aggressive or is it non-aggressive? And it's this tiger or kitten. Is it a slow growing tumor or is it an aggressive tumor? And that's what the challenge that we're faced to determine whether we can do active surveillance. Because nobody wants to be over-treated. You know, if you don't need treatment, why would you subject yourself to therapy, to surgery? And nobody wants to be undertreated. Why would you want the prostate cancer to spread or get worse? So one of the things that, and this has just come up in the last 2 or 3 years, there's been a lot of development and new markers to look at prostate cancer. They're new prognostics. They're here. A lot of these companies are here with us today, where they'll take the RNA or the genomics of your cancer, pull out the DNA, and based on these studies, they can give you an additional predictive chance of this spreading. And when you look at these tests, and they're I call them molecular tests or genomic tests, these are performing at a higher level right now than Gleason grade and PSA and digital rectal exam. So we're just at the tip of the iceberg for these new tests to better determine on who should be treated and who should not be treated. There's about 4 of them on the market today, and as the technology develops, we'll see more and more higher performing tests years going forward, which will tell us whether you have a tiger or a kitten type of prostate cancer. Do we need to treat you, or can we sit and watch you? And that's where these molecular tests or genomic tests will make a huge difference. They're very helpful in the clinic, and they show great utility when urologists use them to help determine who should be followed and who should be treated.